Let's go ahead and get started. Thank you again for joining us today. We really appreciate you giving us some of your time. My name is Sharon Beckwith. I'm the CEO of MDReview, and I'm very excited that we're able to bring you this program today, talking about quality metrics and clinical benchmarks for telehealth programs. We've been able to partner with the Michigan State Association and the Hardenbergh Group to be able to bring you this program, and we've got two great speakers for you today and a lot of really good content. So I'm going to go ahead and get things started here. So just a couple of little housekeeping issues to begin with. Again, all participants are muted. You can submit a question at any time during the presentation. You just click on that Q&A icon on the navigation bar at the bottom of your screen, or sometimes it pops to the top of your screen. If you don't see this icon or this bar, you might just have to hover your pointer over the bottom of your Zoom window and it should appear. We're going to hold questions until the end, and then we'll address them at the end of the presentation. And then just, you know, your continuing education certificates are going to be issued by the Hardenbergh Group, and that should come out within the next week following the program. Maybe give us a little leeway on the Thanksgiving holiday, but we'll get those out to you. So I'm going to go ahead and introduce our presenters today. We've got Dr. Lefkowits and then Gigi Sorenson as well, and I'll just give you a little bit of background about each of them. Dr. Lefkowits is the medical director for us at MDReview. He is a graduate of Dartmouth College with both his undergraduate as well as his medical degree, and then his residency as well. He's been an emergency medicine physician for 40 years, practicing at Rose Medical Center here in Metro Denver, only recently retiring at the very end of 2019 after a long and amazing career. So while he was at the hospital, he served in a lot of different functions, being on the hospital board of trustees, president of the medical staff, chair of the credentials committee, the peer review committee. So he's been involved in many medical staff leadership roles. He supported the hospital and medical staff functions by chairing fair hearings, providing crisis management, press interactions, and developing leadership programs. And now currently, Dr. Lefkowits is the president of the Colorado Medical Board as well, and he's just a pleasure to work with. Gigi Sorenson, who is our other speaker today, is currently the corporate director of Telehealth for Shriners Hospital for Children, and is responsible for strategy and operation for all of their telehealth programming. Prior to that, she was the chief clinical officer and VP of operations for a vertically integrated telehealth company, and was responsible for ensuring clinical integration of workflow processes and provided applicability of products and software developed for the customer. So she's got an amazing background and knowledge with regard to telehealth. She's developed remote patient monitoring, direct-to-consumer, outpatient specialty clinic, and inpatient acute care telehealth programs. She's published on remote patient monitoring program success and partnerships required for success, and she's been the principal investigator on numerous federal grants and foundational funding to develop and expand telemedicine programs across the rural Southwest. Gigi is a graduate of Northern Illinois University with a master's in science in nursing degree, and holds her Lean Six Sigma green belt. So I'm very excited that both of these speakers were able to join us today and to present you with this fantastic information. So I'm going to go ahead and kick it over to Gigi to get started.
Thank you, Sharon, so much for that warm introduction. Don and I are so happy to be able to present to the team in regards to quality metrics surrounding telehealth and the care delivery. So we're going to go back and forth and hopefully impart quite a bit of knowledge for you guys, and happy to answer questions at the end. So today we have three main objectives that we're going to be looking at. We want to list all those essential elements for developing a strong telehealth program. We want to describe our quality metrics and clinical benchmarks related to telehealth for those that's special to your field with medical staff services. And then also give you some clues into best practices related to telehealth. We realize that many of you were thrust into this at a moment's notice when the pandemic was issued. And so we want to help you now, since you've had this sprint. Telehealth isn't going away. Virtual care delivery will maintain, and we want to be able to help you go forward. So we'll go to the next slide, please, Sharon. So I don't know about you guys, but I grew up watching the Jetsons, and I loved this. And who knew that they would be foretelling our medical care delivery and our home life? So many of you are now working from your home at times in your home offices. And I actually, Mr. Spacely there, I actually had a CFO I worked with once that looked just like him. So I always flash back to this. But we're doing online classes, video calls, and they specifically pulled out telemedicine and in their care delivery, where little Leroy was seeing the doctor. And it was interesting, and then they would get billed for it. So who knew that they were way ahead of their time? But we're here now, and we're going to go forward with what's going on. So what I want to review now are some of our definitions, just to get a foundation so that we're all on the same level playing field to get started. So many of you have heard the terms telehealth, telemedicine, virtual care, e-care, et cetera, and it can get really confusing at times when we're trying to sort through all of this. So what I want to do is to kind of step back and take the confusion away and make it just a little bit easier for us. So unfortunately, there is no national definition of virtual care delivery that every state tends to follow. Each state has been allowed to develop their own definitions. So where I focus this is that telehealth is an overarching umbrella with many different forms of virtual care delivery tucked in and underneath it, of which telemedicine is one of them. So think of telehealth as the umbrella, and then all of these other entities roll into it. And some of the states even get very picky about what can go in and under telehealth. And telehealth is not just straight video conferencing. It's the components of care delivery that are needed. Proper assessment, evidence-based protocols, devices that feed information in, et cetera, et cetera. So think of it that way, telehealth as your broad base, telemedicine as a component of. Then you've heard terms of distant site, originating site. What does that mean when you're setting up in regards to providers and credentialing and licensing and where patients are, et cetera? The easy way to remember this is that distant is where the doctor is. So put the two D's together. And it's actually any provider. The provider who is delivering the care is seen as the distant site, with the patient as the originating site. And where this comes into play of needing to have these squared away is primarily in the licensing environment and consenting environment. So always know that where the care is being delivered is considered to be where the patient is. So that's where the provider needs to be licensed. That's if there are specific state consenting rules, that's where that has to go, is at the originating site of where the patient is. So that's that. Then you'll hear terms of synchronous versus asynchronous, real-time versus delayed. And this is one of the original telemedicine terms that came out. Synchronous means that it is near real-time interaction. You have a video connection, the patient is on one screen, the provider's on the other screen, and the care is being delivered in real time, or the legalese is near real time because there may be a half a second delay or something. And so that's what it is. Asynchronous telemedicine comes into play in those environments where information is uploaded by the patient to be reviewed by the provider at a later time during the day. Or for instance, a great option here to think about is an x-ray for a patient is uploaded. The provider looks at it in the afternoon after their office hours are done and then calls the patient to say, here, this is what we need you to do. A picture of a rash, the patient sends that with a either recorded or typed note to the provider going, I don't know what this is, it itches really bad and it's red, and what do I do about it? And then the doc can look at it later and call the patient back to set up, get more questions answered in an assessment plan and a care plan put into place. So that's synchronous versus asynchronous. If you hear the terms RPM, they stand for remote patient monitoring. And what this entails is having the patient have devices in their home that upload information, clinical information, to either a care coordinator, a case manager, a provider, whoever it is receiving this information, so that quick and more complete assessments can be done the patient is doing at home. These are usually devices that are uploaded daily. For example, a scale, so the weight goes forward, measurements of their heart rate, their blood pressure, maybe it's a Fitbit that they're wearing, show the number of steps and minutes or hours active, minutes or hours slept, etc. Those are all things that are then put forward to the provider so that a near real-time trend can be there to look at the patient and where they're going and what, so an early intervention can happen versus waiting for a patient to get sick and call in. So all of these definitions roll into things that you may be seeing if you are new to the telehealth space. So next we'll look at some program development key points. And for those of you who maybe had an established telehealth program, but it was only in a very select area. Maybe your health system was doing telestroke coverage and getting that taken care of, or you had other small pieces. And then when COVID hit, you were thrust into the world of primary care, pediatrics, some chronic care management, home health, assisted living facilities that you had to start reaching out to, et cetera, et cetera. So now as you look back at that as a health system, and your leadership of the health system has now decided that telehealth is here to stay. And we need to look at what the program is. When many programs were stood up, there were a number of relaxations. We'll get into that here in a couple of slides. And so there were some exemptions made of rules that needed to be followed. These were relaxations. They weren't absolutes of you never have to think about this again. So now as you go forward for putting telehealth and virtual care delivery into your normal everyday stride of care delivery, things that your health system will have to look at. And first of all, it's the scope. And your scope is always defined as what we talk about here in the third point, the pain points to solve. And I technically should have put that at the top because that's the number one thing. What are you trying to solve for? What are your patient care needs that are having to be fulfilled? And then what are your provider needs to continue to see care? And how does that all roll into their licensing and credentialing and privileging and all of the Joint Commission or DNV accreditation standards that you need to fulfill? And so what are your pain points? So then your scope is, are you only going to be doing inpatient care that you don't have enough providers or you don't want to be exposing providers in patient to patient and so you're using video connections for virtual care delivery? Or is it only for outpatients, those that can no longer come into a clinic visit, or your clinic potentially is still closed and you don't want a number of patients coming in? Or is it a hybrid model? And then what services are going to be offered? Is it primary care? Are you into the specialties such as cardiology or neurology, pediatrics, dermatology, whatever? And then is this program something that is supported by your own providers in your health system? Or do you need supplemental help from an outside vendor source to come in who has a specialty group, say in acute neurology, who could handle your strokes? Or is it even a hybrid model where you have some providers, but you don't have quite enough to make the full complement to deliver in-person care and do telehealth visits? So do you need to have extra just support maybe? A lot of health systems bring in outside agencies to help support on weekends, nights, holidays, so that their providers can get a little bit of a break. The last thing you look at putting into place, which isn't so much a worry of you all's, but what should the technology be? Technology should always be the last issue that you get for. You have to figure out, number one, what do your patients and providers need? And what are your capabilities? Then look at, okay, what technology do we need to solve this? So then next, we'll look at different kinds of program types. We've mentioned some, but as we go into it, like we talked about, acute emergent needs are always big. And especially since patients, we have seen stories, we have studies even coming out about the drop in the number of diagnosed heart attacks, strokes, et cetera, things that we would normally expect to see in emergency department or urgent care patients coming in for. Patients are afraid to come in. And so they don't know if it's really something that they should come in because they're afraid to be exposed to not only COVID now, but now we'll be going into flu and RSV season. And so what should they do? And so this is a nice way to keep patients actively engaged in their healthcare delivery and then not having to deal with consequences of undiagnosed acute care needs. Urgent care is always great. The last thing you want to do is go sit in a crowded waiting room and or if they're only allowing so many people in their waiting room, sit in a cold car in the winter while you're waiting to get in for an urgent care visit that potentially could have been done through telehealth. Outpatient scheduled visits is probably the number one thing that happened and went into play this spring, so that those chronic care patients, which are next, those chronically ill patients could maintain their continuity of their care delivery, that you weren't missing out on an annual visit, updating what is their blood pressure to renew their antihypertensives that they were on or other medications such as that. So which is very, very important. And then also when you look at your program types, you're gonna have to be ready to address the entire age spectrum, because how do you address from newborns, neonates, pediatrics, into your adult population, and not only age spectrum, but life spectrum as you go forward. And so dealing from everything, as the adage is cradle to grave, and how do you care for everyone? And is that the scope that your health system is willing to take on, or do you need to focus on what's going to happen? All questions that system leadership needs to answer, which helps you then as the MSP department and leadership to know how to build your programs out. And I think, which is very important. Where this all, where we're used to very clear guidelines and standards to uphold that had been longstanding, got kind of tossed up in the air when the public health emergency declaration was put into place early this spring. The PHE is a 90-day declaration that is issued. We've seen it issued in the past, for example, when there was the Zika, Ebola, H1N1 flu, different times in history where there have been major disruptions or potential major disruptions to our healthcare system. You've also seen emergency declarations put into place for localized areas in regards to potentially earthquakes or hurricanes, which are extremely short-lived. These are 90-day declarations. We are on our third extension of this. They are renewed at almost the last minute, literally 48 to 72 hours before it's due to expire. And what this has done for health systems in regards to telehealth is that it has put in many of the relaxations to standards, guidelines, rules, and regulations that were in play. It also allowed additional funding to be put into place for health systems, FQHCs, et cetera, to be able to draw from in order to support the work. And specifically in the realm of telehealth, allowing monies to be available to purchase hardware that was needed, whether it was cameras, software systems, phones to give to patients, tablets to give to patients or providers, et cetera, that it was there. And so you have to sit back and go, okay, with the PHE in place and new relaxations, new guidelines, and new policies that come out, and then the state started to pick up on how am I as a state going to interpret this and go forward. And then you have Joint Commission and DNV in there also responding to this. It is so confusing for you all to try to keep up on. But how it is influencing you is you need to look at. In the past, there were certain sets of providers that were able to bill and then receive reimbursement for delivering virtual care. That has been expanded dramatically, most notably in the field of therapy services. PT, OT, speech, historically haven't been able to bill and receive reimbursement, but now they can. And licensing standards, there's now emergency licensing that can be requested and obtained. Credentialing relaxations when they're going forward. Billing and reimbursement. Not only could the provider bill now, but get reimbursed where in the past they couldn't. The patient didn't have to be in certain locations in order to bill and then receive reimbursement. The most noted and the most welcome change was that the home was now seen as an established site for care delivery, as an appropriate care delivery site, so that patients didn't have to leave their home. This was the number one thing that was changed. And also, that made a huge impact. And now it'll be interesting to see, we'll chat real briefly about going forward. And then also in the world of technology, there were very strict criteria in place for cybersecurity in regards to what type of video visit software platforms could be used. And it was all based around security and privacy of information in regards to the HIPAA and high trust laws. And so this had some relaxation put into place, but what we're seeing is that this is going to get tighter and tighter. And hospitals are going to have to react to this about what are appropriate platforms that you can use to make sure that your patients and their health information are safe and secure, along with other things. Secretary Verma from CMS, who guides most of the telehealth rules and regulations, has said in the past and continues to say that the genie's out of the bottle, and so telehealth is here to stay. So what I want to do is turn it over to Don and let him start going through all of the key quality metrics and benchmarks that you all have to do. So Don, take it away.
Great. Thank you, Gigi, and thank you everybody for being here and listening. It's always a little strange not being able to see our audience, but hopefully so far you're engaged. And as Gigi said, this telehealth is a great example of the adage necessity is the mother of invention, and I recall, as Sharon mentioned, I've just finished a 40-year career in emergency medicine. My first exposure to telemedicine was actually called teleneurology. That was the first time a camera showed up in our ER. And it was for a very good clinical reason. You probably remember back 10, 15 years ago, when stroke care was a very depressing thing. When a patient would come into the ER with a stroke, there wasn't a whole lot we could do to reverse the process that was causing the stroke. It was mostly just to keep them safe and start rehab as soon as possible. And then we got the TPA, which more commonly known as the clot busting drugs. And the studies began to show that the faster you were able to give the medicine, the more likely you could reverse the devastating consequences of a stroke. So patients started showing up, and family members would come in with a stroke patient, and they'd want to know where our neurologist was, as if the ER doc just kept a neurologist in his back pocket and was able to bring out a neurologist and say, okay, here's the neurologist. They're going to determine whether you're a safe candidate for TPA or not. You probably know that this clot busting drug has dangerous side effects, but also can be life-saving. And so we developed the teleneurology camera, which by definition had to be very detailed. The neurologist, who couldn't actually be at the bedside the moment the patient rolled in, could actually get on a camera within 5 minutes, but the camera had to actually allow that neurologist, with the consultation of the emergency physician, to determine whether or not this patient can receive this potentially life-saving medication, which also could potentially cause significant harm if given in the wrong circumstance. And just to show how far we've advanced, we now regularly in the emergency department have what's called the door-to-needle time, meaning from the moment the patient arrives at the door of your ER to the time you start administering the drug of less than 20 minutes. Which means the patient gets brought in, registered, assessed, seen by the neurologist on the telemedicine camera or teleneurology camera, gets a CT scan of their head, because you have to make sure they're not bleeding into their head, and then gets the drug administered to start reversing the consequences of the clot causing the stroke in less than 20 minutes. And that's just would not be possible without a camera, a high resolution camera at the bedside, where a neurologist could almost immediately start assessing the stroke patient. The next area that it then expanded to was telepsychiatry. I practiced for 40 years in an urban ER. On any given day, 10, 20, maybe even 30% of our patients were in the ER because of mental health concerns, acute on chronic exacerbations of mental health conditions, acute suicidality, overdoses. And before a patient can be determined to be safe for discharge or placed on a 72-hour mental health hold, we would have to get a psychiatric evaluation either by a psychiatrist or a psychiatric social worker. In the olden days, we used to have to wait for that person to show up in the ER, and they'd be spread pretty thin, going from ER to ER doing these assessments. Well, 4 or 5 years ago, we realized that many, perhaps not the most acutely psychotic patients, but many of the patients could actually be seen by telepsychiatry telehealth. And that took an enormous burden off of the emergency department in terms of staffing and bed utilization, and has also made a huge difference. So as Gigi mentioned, and then comes the public health emergency of the COVID pandemic. And here we have a dramatic broadening of the use of telemedicine and telehealth for good reason, because of its efficiency, its safety. So let's talk about what constitutes or how do you best go about starting a telehealth program, monitoring your telehealth program, once it's up and running, to make sure that you're checking all the boxes and providing high quality care. It starts with training and education. It is very tempting to throw a headset on a provider, physician extender, PA, nurse practitioner, throw them in front of a computer and let them dive in. And we caution against that, because there are some basics that really should be in a form of an education and training regarding telehealth, to make sure that the providers understand the appropriate limitations of telehealth, when to insist on in-person evaluations, how to set appropriate expectations. And as you can see, I think you've all received our quality metrics for telehealth booklet. There are already online resources for educating your providers, whomever it is going to be providing the telehealth services. Once you've begun a program, how do you, and by the way, the training needs to be fairly comprehensive because it should talk about office setup, professional appearance, proper headset selection, software platforms, safety procedures. It's not necessarily that easy to just call 911. You have to have an emergency plan if you think the patient you're evaluating by telehealth needs to be seen emergently. You have to have protocols in place, mechanisms for prescribing if that's going to happen, and how to address perhaps labs, x-rays, other testing that needs to be done, and arrange for follow-ups. We'll talk a little bit more about that in a little bit. When you do start wanting to evaluate how you're doing, once your program is up and running, it's not that different than in-person quality metrics. And specifically, you're probably going to start with chart review. And again, the expectation should be similar to what you would do for in-person. How documentation has occurred, is there consent process, is there clarity of diagnosis and a treatment plan, follow-up instructions. And one of the things that you will probably want to track is something we track often in the emergency department, which is unscheduled return visits. You've seen the patient, you've dispositioned them, arranged for appropriate follow-up, and it turns out they're seen either in an urgent care or an emergency department within 24 hours of that visit with a perhaps higher acuity problem. That's a chart that you're going to want to look at with more detail. Let's go on to the next slide, Sharon. Thank you. So another element of your quality metrics would be compliance with best practice, established best practice guidelines. Again, same as in-person visits. What are your limitations for telehealth? How has your screening process gone in terms of what telehealth is appropriate for, what diagnoses or presenting complaints? There are a long list of things that a provider can actually assess for over telehealth. Minor GI complaints like acid reflux, allergic symptoms, at least if they're not acute and emergent, chronic diabetes management, other chronic conditions like gout, hypertension, COPD, some potential medication adverse reactions or reviewing medications. Many minor injuries that maybe don't necessarily require sutures or x-rays, or the patient really just wants to know, is this something that needs stitches or x-rays? And those are things that certainly can be done through telehealth. Another thing that is important to monitor is prescriptive patterns. And one of the things that we've noticed early on in general and especially acute care, urgent care telehealth is this is an easy area for abuse. One of the things that we've seen early is that patients want to get on a telehealth visit and their first statement is, "I just need my Z-Pak," which is a common 3-day medicine for basically earache, sore throat, sinus congestion, cough, mostly viral illnesses that don't need antibiotics, but patients feel like they get better faster generally from a placebo effect if they get a prescribed antibiotic. So monitoring the percent of patients who receive antibiotics, the appropriate use of antibiotics, perhaps through your pharmacy therapeutics or pharmacy stewardship committee, an important element to monitoring your care. It's easy for a patient over telehealth to just say, I just feel like I need an antibiotic, and for a provider to sort of let down their guard a little bit and just make that arrangement. So something to monitor. An even more important area is controlled substances and protocols for prescribing, generally the basic rule of thumb is probably going to be that if you're doing a telehealth virtual visit, you're probably not going to be comfortable prescribing controlled substances, unless it's a long-standing chronic patient use, chronic pain management patient, and that usually should be handled by the patient's primary care physician. Now, in the setting of a primary care physician who's taking care of a patient who can't come in for a direct patient visit, in-person patient visit, it's probably reasonable to continue regular medications. But if somebody is in need of a new prescription for a controlled substance, that's probably going to end up being somebody that needs to be seen in person, rather than through telehealth. Let's move on to the next slide. So additional quality metrics and benchmarks. So as we do with in-person visits, it's important to try to assess whether patient satisfaction is high. If there are patient complaints, they should be followed up just like any in-person patient complaint. It's interesting that although sort of empirically, you might think that it's harder to establish an effective patient rapport with a patient who you're seeing via telemedicine. It actually turns out that telehealth patients are perhaps even more appreciative of the service they're receiving than in-person visits, because it's made it so much more convenient for them, whether it's having to obtain childcare or transportation, or they're just feeling too bad to leave their home. And so actually patient satisfaction scores have been found to be higher on average than in-person visits just because of that. But you still want to pay attention. There's no reason to not include telemedicine patients in the same survey mechanisms that you have established for your in-hospital or in-office surveys, and see what kind of results you're getting. Follow up on patient complaints like you always would. And then monitoring for completion of care plans. It's less common for patients to leave a visit before they've completed their care plan. We do monitor, like for instance, in the emergency department, we monitor what we call elopements or left before completing care. That should be a low percentage. Probably on telehealth, that should be an even lower percentage, and that's certainly something that you can monitor. You also want to be able to monitor for appropriate use of against medical advice forms and documentation. It's probably more likely that a patient being evaluated by telehealth, when a provider is concerned and wants to schedule same-day follow-up or next-day follow-up, or even perhaps immediate referral to the emergency department, and the patient is reluctant to do that, that needs to be documented well, and even to the extent of having them complete an against medical advice documentation form. So let's move on to the next slide, on slide 15. You also want to be able to assess for professionalism, and that can include multiple elements. I think Gigi has already talked about, what it takes to execute an appropriate telemedicine visit in terms of what the workspace looks like. Is it a quiet setting? Are there interruptions? I'm babysitting my 3.5-year-old grandson today, and I half expect him to walk in any minute and say hello to all of you out there. That's probably not appropriate, wouldn't be appropriate for this presentation, and it certainly wouldn't be appropriate for a telehealth visit. Dress professionally, speak in a normal volume, try to make sure that you look into the camera lens, because that's actually the way that you make eye contact. Is the provider conducting visits outside of established protocols? Meaning, if a patient has been screened for a telehealth evaluation, and it turns out they start describing a condition that is more worrisome or may require more urgent evaluation, has the provider recognized that early on, stopped the visit, and arranged for either a family member an ambulance or some other mechanism to get that patient more urgent evaluation, in a quicker fashion. In terms of time of length of visit, what's an appropriate evaluation for a patient over telehealth? You want to make sure you're aware of what your payment model is to the provider. Some of the ones that I've seen recently are productivity based, which means there's an incentive for the provider to actually conclude the visit as quickly as possible. And that may end up missing an important element of the patient's history or presentation. That may mean a very limited evaluation of the patient's complaint. And you want to make sure that the length of the visit is appropriate for whatever the diagnosis and treatment plan that's established for the patient. Gigi talked about technology, and one of the things that's in part because of the availability of telehealth, our smartphone and other devices at home are becoming more and more sophisticated about the information that can be transmitted about a patient's condition. Pulse oximetry reading, heart rate. Our high resolution cameras on cell phones now can show rashes and lacerations. And I've looked at patients' throats via a high resolution camera on a phone and am able to see things that are probably very little different than what I would be seeing in person when I look in the throat. And so the availability and appropriateness of use of technology, I think that's going to be something we're going to expand on more and more as time goes on. I think you're still going to have to come to the hospital to deliver a baby, but short of that, there's a lot of things now that we can do remotely in terms of making assessments of the patient's condition. Timeliness of response, you should be able to schedule accordingly and keep patients from waiting extensive periods of time. That's something that's easily tracked and, again, contributes to patient satisfaction. One of the things that we found is that a patient being able to schedule an online appointment where they usually register and get the demographics put in 5 to 10 minutes ahead of the visit. And then when the visit time comes, the provider is there. It's an enormous plus for patient satisfaction when they've been used to waiting in an urgent care and emergency room, waiting in a physician's office because they're running behind. This is a way to really enhance their patient experience. Additional system-based practice guidelines. Plugging a patient in. So at least for unscheduled, for urgent care, emergency care, or visits that aren't constituting a chronic established relationship with a patient, what happens after the visit is critical. How is the patient going to be plugged in for whatever they end up needing, whether it's testing, whether it's labs, whether it's prescriptions, whether they need to be referred to a specialist. The system that is established to allow for appropriate referrals, schedule follow-up, plug them into a clinic. Maybe they already have a primary care physician. You're able to plug them into an appointment for that primary care physician. Or if they don't have a primary care physician, do you have a referral list based on insurance or lack of insurance, outpatient primary care clinics, a place for the patient to follow up so they aren't lost, they don't fall through the cracks and get lost in the shuffle. The completion of documentation. Most telehealth practices have developed a template that is telehealth specific, because obviously there are some limitations to what a telehealth visit has that is different than an in-person evaluation. And so you need to be careful that your telehealth template for documentation takes that into account. We've seen, the checklist documentation of a telehealth visit that describes having done parts of a physical exam that aren't humanly possible by telehealth, and you don't want to really, end up creating fraudulent conditions or situations where you document things that just can't possibly have happened. We're running late on time, so let's just move on to that next slide. And I think, Gigi, I invite you to jump in here on office setup, personal appearance. I referred to some of those things, and especially the technology issue and the at least temporary relaxation on some of the HIPAA requirements regarding technology, and how that does give us some leeway. Although, as Gigi mentioned, within short order, the CMS and auditors will start looking more carefully at the HIPAA compliance of whatever technology you're using to communicate with patients. But for now, you do have a little bit of leeway. Gigi, your other thoughts on this slide?
I think the only other things that I would like to put forward on this slide are is that you've covered it nicely, Don, in many things, and it's when you are looking at providers, just be cognizant that a provider can't do a virtual visit, a telemedicine visit, just anywhere. They need to be in a secure, professionally looking, safe area so that the information exchange that is happening is done securely. You sure don't want them taking a call as they're walking down the hallway or sitting in the cafeteria or out and about at Home Depot, for example. So always make sure that you are setting your providers up for success in regards to how they can best care for their patient. Set the standard as if the patient was still coming to the office. What should it look like? What should it feel like? How safe should the patient feel that their information is going to be secure? So I think that's the last, big point that I want to put up because many things have already been discussed.
Great point. So another anecdote. Sharon knows I love to tell stories. This is a true story. A telestroke neurologist comes on. He's actually the backup neurologist because the actual on-call neurologist is already doing a different telestroke evaluation. So being the backup, he wasn't expecting to necessarily get a call. And it turns out he and his family are at a Mexican restaurant. And he gets on the camera, and wouldn't you know it, just at that time, the roving mariachi band decides it's time to serenade their table. And so we're trying to conduct an emergent telehealth neurology assessment of the patient with mariachi band music in the background, which at that point he excused himself and went outside and continued the evaluation. But yeah, appropriate setting for your interaction with the patient, certainly important to consider.
Yeah, most definitely. And don't let yourself get caught when new standards come in for the unrelaxation in regards to technology, especially. So make sure that your health system and your practices are preparing for what will be the long-term expectations.
Great.
So I think.
Next slide, Sharon. Yeah, so what's the future? Is this all going to go back to the way it was before the pandemic? Certainly not. It's changed how we provide care. It provides a level of safety, a level of convenience, and a level of efficiency for much of the care that we're able to provide. That's going to mean that it's here to stay. A couple of things that jump out of here on this slide, easing physician shortage crisis. So one of the things that's happening with this pandemic is it's becoming, we've heard about PPE shortages, testing shortages, bed shortages, but what it's going to turn out to be is that our most precious resource is going to be our human resource. Frontline care providers, nurses, physicians, PAs, they're wearing out, they're burning out, they're getting sick. And so how does telehealth contribute to that or help ease that issue? We are already seeing circumstances now where frontline providers who are either quarantined or actually convalescing from a recent COVID infection are allowed to safely contribute by doing telemedicine. And this can help alleviate some of the demand on our frontline providers. And so that's critical. Expanding to clinical expertise to underserved areas. Specialty clinics that can be established for rural patients who would never be able to get to see a vascular surgeon or a nephrologist or another unusual or low supply specialist where it's clear, or they'd have to travel 4, 6, 8 hours to go see that specialist. Being able to get some of that specialty expertise to underserved areas, certainly another highly effective benefit from using telemedicine. Future public health crises. This probably is not going to be, as hard as it is to accept, our last pandemic. And so next time one happens, we'll be more prepared and ready to help along the way and provide that level of backup and expertise. For those of you who are just early on in the start of your program, recommendations: start small. Limit your initial numbers. When it's up and running, the demand may grow rapidly. And if you try to expand and meet that demand with rapid growth, that's apt to lead to some clinical errors. And so you want to make sure that you're able to control your growth, add providers after they've had education, make sure you're watching your internal processes to make sure there is room for growth, and don't try to grow too fast. Gigi, other thoughts on some of these?
Yeah, absolutely. And I think, your last statement was the one that I would really like to emphasize again, is that we put things up in a crisis. It was an absolute sprint to figure out how to take care of patients. Now we're in the long haul of this. And so as you decide whether telehealth is going to be a go-forward strategy for you or not, do it to the pre-pandemic standards. The highest level of security, the highest level of quality, evidence-based protocols, so that your patients and providers all feel extremely satisfied in the end that care was delivered and this is a good way. The other thing to consider now is that the public, your patients, will demand this type of care delivery also going forward. And so how are you going to address that need? Where in the past, patients requesting virtual visits was in the low single digits. We're now seeing data coming out that patients expect this to be a routine offering for them. And providers are expecting anywhere up from 35 to 40% of their ongoing care delivery to be virtual. So be ready and be prepared, and we hope that's what today's discussion has helped you formulate some thoughts and questions as. And I think we have a couple minutes left. Sorry, you put two chatty people together and this is what you get, but
Thank you, Dawn and Gigi, so much. And we do have some questions, so I'll go ahead and get those out to you. And then I think what we can do is any of the questions that we don't get through, we'll go ahead and we can circulate some answers on those. So we have one question here. Here's a scenario for you. So providers from an SC health system, so I believe it's South Carolina Health System, are providing telehealth services for a health system in Georgia. Do the providers need to be credentialed and enrolled in the Georgia Health System's payer contracts for reimbursement for the telehealth services?
And the answer to that would be yes. They also need to be licensed in the state of Georgia.
Yeah, so there is some question. So the waiver, you'll hear of the 1135 waivers. The 1135 is the section of the Social Security Act. And there is some reference to some licensing flexibility from state to state in terms of emergent needs. For instance, when the East Coast was inundated with patients and New York, especially, hospitals needed help, there was an emergency grant of licensing for physicians who came from out of state. They didn't have to obviously wait the 90 days and go through the process. But for telehealth services, in general, you should assume that if you're going to provide, if you're in one state, the patient's in a different state, you need to be licensed in the state where the patient resides, beyond where your own practice is. Now, there is a Interstate Medical License Commission now where I think it's up to maybe 42 states participate. So it's quite a bit easier now to get licensed in multiple states. I would encourage your potential telehealth providers to look into the IMLCC to license in surrounding states so that you'll be ready for this. If you establish an effective telehealth program, neighboring state patients are going to call in and want to get help. I guarantee it.
Great. Thank you. Okay, maybe let's try to get to a couple more. So here's one from a person that works at a critical access hospital and rural health clinic, which typically are not allowed to conduct telehealth visits. This has not been relaxed for RHCs, but I can also say our providers are not necessarily up to date on the rules around these visits. Recently, there's been discussions regarding where the patient is located and whether or not services can be provided for patients that may be in another state. It's always been my understanding that the provider must be licensed in the state where the patient is. Is that correct?
Well, I can start on this one. In the Public Health Emergency Declaration, RHCs and FQHCs are now allowed to not only do virtual care delivery, but bill and get reimbursed for that through the PHE. And the home is seen as a site of care, where in the past a patient would have had to be at another clinic or established facility. They can be in their home for that care delivery. And so a lot of relaxation, and it is, you know, it is brand new. The language, you know, you have to look at your state too, but this is a federal declaration. And so, yes, you can. And so it is getting a comfort level on your providers to make, because they're not used to doing it in the past, but it is something they can provide in the patient's home. And yes, they do need to be licensed in the state where the patient is residing.
Great, thank you. Okay, how about another one here? How can a hospital address admitting patients using telehealth?
We've seen many hospitals use that virtual connection to get all of those pre-health assessments done, consenting signed, et cetera, even pre-op visits where they would typically come in to see a nurse in the surgical services department to get their assessments done. So all of those types of visits can be done with the patient in their home using the secure video conferencing systems.
Great. Okay, we have a couple questions about slides. The slide deck, yes, we'll share information. The presentation will be available afterwards. And we will also share, Dr. Lefkowits had referred to the MDReview telehealth guide booklet that we had put together. We'll share that as well. So let's see if we can just sneak one more question in. And this is a big issue apparently that this person is having, they're having an issue with patients forgetting about their telehealth appointments. So the question is, are we allowed to send them a text message as a reminder, or do they have to allow for that option?
Patients need to allow to be able to receive text messages just because you're using their data plan to get them. And so that is one issue. But you are allowed to offer that texting reminders can be sent. And it's not that, Mrs. Smith, you have an appointment with Dr. Jones to talk to him about your rash. It is a more generic, where they would get a reminder to maybe potentially click and then get direct.
Great, perfect, thank you so much. So again, if you want to go ahead and get your CE credit for this program, you'll be getting a evaluation post-event. You just need to click that link, complete the survey, and then you'll get it. And we really appreciate everybody joining us today. If you do have any questions, please go ahead and either contact the Hardenbergh group or MDReview. You've got information there on the screen. Feel free to reach out to us with any questions. Thank you both, Gigi and Dr. Lefkowits. The information today I think was fantastic and super helpful. And appreciate everybody joining us today. And Gigi, I'm just going to pass along. Looks like you're getting some personal shout outs from the folks at Shriners in Boston. I just want to let you know that. So they're saying hi.
Thank you very much.
Hey, Sharon. Sharon, it's Don Lefkowits.
Yes.
One last plug. No, Sharon knows I'm going to do this because I do it every time. You all work in facilities based on science and care of patients. So I encourage you all to get your flu shot, wear a mask, stay socially distanced, and have a safe but small party Thanksgiving. Take care, everybody.
Thank
Thanks.
you.